Okay. Now I'm going to ask Dr. Jankovic to talk about botulinum toxins, indications, benefits, and limitations. And I just pulled out 2 questions regarding botulinum toxin that I'll mention, and maybe Dr. Jankovic can address these during his talk. What's the long-term effects of using botulinum toxin, and how long can a person take botulinum toxin? Okay, thank you very much.
Okay, so yeah, these are 2 good questions that I was planning to answer anyway, so that's good. So hopefully we are not going to waste any more time. We are about 10 minutes behind, but we'll try to catch up. But I still want to be able to address a lot of the questions that may be on your mind. So before we start talking about therapy, I thought it might be useful to discuss with you how we actually assess response to therapeutic intervention. So there are a number of tools that we use to assess the response. These are mostly clinical tools, meaning they are sort of rating scales that the neurologists use to assess the severity of the blepharospasm and how the blepharospasm interferes with functioning. And these are, one of them is called the Jankovic rating scale, I don't know who it's named after, and the Blepharospasm Disability Index. So those are the rating scales that are most frequently used. And then there are rating scales that are designed to assess quality of life and the effect of blepharospasm on various activities, including emotional well-being, pain, and so on. It's called Cranial Cervical Dystonia Questionnaire, CDQ-24. And there are a number of other tools and instruments that are currently being used or investigated as a way of measuring or assessing the response to treatment. So if you look at the literature, most of the rating scales that assess the effects of botulinum toxin use the JRS or the Blepharospasm Disability Index, and there's a good correlation between those 2 scales. One is assessing the severity and the frequency of the blinking and blepharospasm, the Jankovic rating scale, and then the other one is looking at activities of daily living. There are many other issues that are related to blepharospasm that these rating scales may not address, and I know there's another rating scale that's in development to assess other aspects of blepharospasm. So before I talk about treatment, I just want to show you an example of a patient who either is not treated or the treatment has been delayed so to the point where botulinum toxin may not be useful, and that's exactly what we want to prevent. So here's a patient who has a long-standing blepharospasm, and as a result of the contraction of the eyelids, he has developed what's called dermatochalasis, and he demonstrates it here. So he has developed stretching of the skin and over the eyelids, and obviously botulinum toxin is not going to help this patient. This patient is going to require eyelid crutches, like he's using right now, or some kind of a oculoplastic procedure. So we obviously want to prevent the development of dermatochalasis and want to treat blepharospasm fairly early. If you are interested in eyelid crutches, I know the Blepharospasm Research Foundation has information on the website. This is an example of an eyelid crutch that one of our patients is using, and here's a website for those of you who are interested in using these eyelid crutches. You just need to talk to your optometrist and see if they are interested in working with you to put these eyelid crutches on the glasses that you are wearing. So let's talk about botulinum toxin, which clearly is the most important advance in the treatment of blepharospasm. You can imagine what we had to deal with when we were seeing patients with blepharospasm before botulinum toxin. There were very, very few options that were available to us. We used medications such as clonazepam or trihexyphenidyl. There are some other medications, but I'll be the first one to admit that those medications were not terribly effective and were associated with a variety of side effects. So I was very fortunate to start working with Alan Scott and others in the development of botulinum toxin, and eventually probably brought it to the attention of Allergan, and finally botulinum toxin was eventually approved for the treatment of blepharospasm and other facial spasms. Many of you know that botulinum toxin is a very potent toxin. It's the most potent biologic toxin known to man. It is listed as among the 6 highest risk threats of bioterrorism by the CDC. Fortunately, the way we use it, it's obviously not a threat. If I gave this talk a few months ago, I would tell you that there are only 7 serologically distinct toxins. Now I can tell you there are 8. Just in the last few months, another type of botulinum toxin was identified. So there are 8 different types of botulinum toxin, and it's very important when you read the literature that you know exactly what type of botulinum toxin they are talking about. Not every botulinum toxin is the same. They all have different properties, different potencies, and it's extremely important for you to know that you know exactly what type of botulinum toxin the article is talking about. I'm not going to go into a lot of the details how botulinum toxin works, but sometimes in the lay literature it is often described as a paralyzing agent that paralyzes your muscles. Well, not really. What it does, it relaxes the muscle. It is a fairly complex molecule, as you can see here, but basically it consists of a dye chain, meaning there's a light chain and there's a heavy chain, and it's the heavy chain that binds to the muscle and eventually gets incorporated and causes this inability to release a neurotransmitter called acetylcholine from the nerve to the muscle. So by cleaving or cutting these various proteins that are important in the docking of the vesicle in a nerve that contains the acetylcholine with the muscle membrane, it prevents the release of this acetylcholine, this neurotransmitter, from the nerve to the muscle, and thus weakens the muscle. So that is the mechanism by which botulinum toxin works. And again, the different types work on different parts of this mechanism. So, for example, botulinum toxin type A, which is Botox and Xeomin and Dysport. I'm using the brand names because the generic names are very difficult to pronounce, but I'll come back to that. And then botulinum toxin type B, they work through different mechanisms, and I don't expect you to be experts on how these different types of botulinum toxin work, just as long as you understand that different botulinum toxins work on different mechanisms and they have different properties and different potencies. So there are really 3 steps by which botulinum toxin works. This dye chain, the heavy and light chain, binds to the muscle membrane through the heavy chain, as shown here, and then the whole complex gets into the presynaptic nerve terminal, the nerve, and it's the light chain that acts as the active molecule. The reason why I mention this is because many of you probably have heard about zinc, and zinc is a metal that works with the light chain. The light chain is called zinc peptidase. It requires zinc for it to work, and the light chain then does the work. It cuts these different proteins and again prevents the release of the acetylcholine from the nerve to the muscle. Okay, so I'm trying to simplify 20 years of research into 2 minutes. So there are different types of botulinum toxin again, and here I use the trade names that all of you are familiar with, and then I also provide the other names that FDA assigned so that when we report various scientific data on botulinum toxin, we are required to use these generic names and not the trade names for a variety of reasons. So when you read an article about botulinum toxin, it may not even mention Botox, it may not mention Dysport or Xeomin or Myblock. It just talks about onabotulinum toxin A, abobotulinum toxin A, incobotulinum toxin A, and rimobotulinum toxin B, which are the sort of the generic names that for these products. Again, each product is different. They are prepared differently. They are diluted differently. They are stored differently. They are indicated for different diseases. For example, botulinum toxin A is indicated for all these conditions that I mentioned here. And again, there are different indications. Just because the product is approved by the FDA for these limited indications, it doesn't mean it cannot be used for other indications. You have to work with your doctor to get your insurance to approve the product for other indications. So once the drug is approved by the FDA, the doctor has the right to use the medication for other conditions other than those conditions for which the drug is approved. That's perfectly legal and clearly medically often necessary. So fortunately, we were the very first recipients of a grant from the Blepharospasm Research Foundation to study the effects of botulinum toxin in blepharospasm. And this was the very first double-blind control study on botulinum toxin. The results of that study were used by the FDA to eventually get the botulinum toxin approved for the treatment of blepharospasm. So this is just a summary of that study we published a long time ago. Again, it was the first placebo-controlled randomized trial for blepharospasm, and also was the first study supported by the Blepharospasm Research Foundation. So I'm very grateful to the foundation for supporting the study. Since that time, there have been a number of studies with botulinum toxin for the treatment of blepharospasm, cervical dystonia, a number of other forms of dystonia. I just want to draw your attention to this study where the investigators actually compared two types of botulinum toxin, namely incobotulinum toxin and onabotulinum toxin, also known as Xeomin or Botox. And in the case of blepharospasm, they found that there was no difference basically between those two products in the treatment of blepharospasm. This study was a study where we took patients who may have been previously treated with botulinum toxin type A, like onabotulinum toxin, and then we randomized those patients to receive either incobotulinum toxin or Xeomin or placebo. And what we found was that both the JRS and the Blepharospasm Disability Index, the BSDI, improved, and the primary outcome measure was the effect on the JRS. So you can see that those patients who were randomized to receive incobotulinum toxin A had a significant improvement at 6 weeks from baseline compared to those randomized to placebo, as noted here. So patients treated with incobotulinum toxin had a significant reduction in the JRS score, whereas patients randomized to placebo had actually worsening during that 6-week period when they were treated with placebo. So this is just an example of a study that compared active drug, in this case incobotulinum toxin, to placebo. There have been many other studies using incobotulinum toxin for the treatment of blepharospasm. Unfortunately, there have been very few studies actually, other than the one that I mentioned on onabotulinum toxin, but many of these studies compared onabotulinum toxin to incobotulinum toxin, and many of these patients were previously treated with onabotulinum toxin. One of the questions was, what are the long-term effects? Does botulinum toxin actually last? And so we looked at this in a population of patients, 45 patients who were treated for at least 12 years consecutively without interruption with botulinum toxin. And these patients had a variety of dystonias. Most of them had cranial cervical dystonia, blepharospasm, and other forms of dystonia. So what we found was when we compared the initial response to the last response, and in terms of the number of units, we had to increase the number of units from 154 to 221 units from the initial injection to the last injection about 12 years later. The latency of response, in other words, the time the patient is injected to the time they notice the improvement, it decreased from about 6 days to about 4 days during that course of treatment. And the duration of response, we divide into maximum duration, the maximum improvement versus total improvement, actually increased during that 12-year follow-up from, at least in the maximum peak, from about 9 weeks to about 14 weeks, and in total 12 to about 15 weeks. And then the peak effect, which is a measure that we use to assess response. It's a 0 to 4 rating, 4 meaning complete resolution of the dystonia, actually improved during this 12-year follow-up in terms of the overall peak effect and global rating. Global rating refers to the peak effect, and we subtracted points if the patient had side effects. Again, the vast majority of patients had a very robust improvement in their dystonia during this 12-year follow-up. Let me show you an example of a patient. So you can see that she has cranial cervical dystonia, blepharospasm, oromandibular dystonia before she was treated. After botulinum toxin injection, her eyes were open, her jaws were relaxed, so she clearly benefited. And if I could have the sound, I'm going to ask her to tell you what happened 15 years later, 15 years after the initial injection. Ma'am, it has been at least 15 years since we first injected you with botulinum toxin.
Right.
How would you compare yourself now to the way you were before the very first injection?
Well, now I have no symptoms of the disease at all that I have to contend with. Before I saw you, I was almost incapacitated completely. I couldn't open my eyes. I was having trouble eating because my muscles in my face wouldn't cooperate. And I had just about decided that I was going to be an in-house patient. And then I was recommended to you, and we started on the Botox, and it's been uphill ever since. It's great. So she has continued to respond. More recently, we looked at a 20-year follow-up. So again, we were among the very first centers to use botulinum toxin. Our first patient was injected, I think, in 1981. Between 1981 and 1996, we treated 1,636 patients with botulinum toxin. Most of those patients had dystonia. You can see majority of the patients had cervical dystonia. Some had cranial dystonia, spasmodic dysphonia, oromandibular dystonia, tie-up dystonia, blepharospasm, torsion dystonia, and so on. You can see that we had 89 patients that have been treated now for 20 years consecutively. So, and even in that group of patients, the patients continue to benefit from the injection. And we concluded that this was the longest reported treatment with botulinum toxin, which provides evidence that these patients' chemodenervation, which is the term that we use for the treatment with botulinum toxin, provided sustained symptomatic benefit, and only 19% of all treatment cycles were associated with adverse effects, but they were all tolerable and transient. Most of the side effects that we see with respect to treatment of blepharospasm include transient ptosis or droopiness of the eyelid that may last 2 or 3 weeks, maybe a couple months even. Blurring of vision that we talked about earlier, which may be due to misalignment of the eyes due to weakness of one of the muscles that moves the eyes, so the patients may have double vision or blurring of vision. And those are probably the most common side effects. Again, there has never ever been a permanent side effect reported from botulinum toxin. All of these side effects that have been reported have been transient. More recently, we have sort of summarized the literature, which was based on various studies published up to that time. Dr. Hallett was the lead author. I was the last author. But in this sort of a consensus evidence-based review, we concluded that for cervical dystonia, at least, there was a level A recommendation for essentially all the products, botulinum toxin. For blepharospasm, we also concluded that there was a level A evidence. Level A is the highest evidence that you can achieve, that it was a really solid scientific data to indicate that at least onabotulinum toxin and incobotulinum toxin, again, Botox and Xeomin, were clearly effective. There was somewhat less evidence for abobotulinum toxin or Dysport, and there was no evidence for myoblock or the rimobotulinum toxin with respect to blepharospasm. And I'm not going to go into the other focal dystonias that we examined.
So let me show you an example of a patient who has both blepharospasm and apraxia of eyelid opening. This patient actually has an underlying condition called progressive supranuclear palsy, which is a Parkinsonian type condition. She's unable to open her eyes before the injection without prying her eyes open with her fingers. So she has blepharospasm and also this apraxia of eyelid opening that I mentioned before. But after botulinum toxin, she is able to keep her eyes open, and not only is she keeping the eyes open, she's able to close the eyes and voluntarily open the eyes. So clearly the botulinum toxin was effective not only in treating her blepharospasm, but also the apraxia of eyelid opening. As you know, botulinum toxin is now used for many conditions besides treatment of blepharospasm, and I submit to you that there is no drug on the market that has more indications for various conditions, not just ophthalmological or neurological condition, but just about every field of medicine is now using botulinum toxin for the treatment of a variety of conditions. There are virtually hundreds and hundreds of conditions that are currently treated with botulinum toxin. If you want to learn more about botulinum toxin, this is a book that we published together with Dr. Hallett and other investigators that has lots of information, much more information that you want to know. And if you really want to learn about botulinum toxin, you are all invited to join us in Lisbon in January. We don't provide transportation, but you are welcome to join us, where we're going to talk about everything you always wanted to know and more about botulinum toxin. So please come and spend some time with us in Lisbon. I just want to conclude by paying tribute to the founder of the Blepharospasm Research Foundation. I had the honor and pleasure to not only know her, but to participate in her care. Mary-Lou Koster is clearly one of a kind, and every time I talk about her, I get choked up. But I was honored to say a few words in her memorial, and I said the following: I will always hold on to the memory of this most remarkable woman and be eternally grateful to her for the legacy she left behind, especially her daughter, Mary Lou, and the army of loyal followers like you. So I want to conclude with that. And this is my sister, Mary Lou. Her mother always referred to me as her other son, so that makes me Mary Lou's sister. I told her many times I never shared chocolate with anyone except with her. This was in celebration of her 39th birthday, I think, right? It was 30. And this is a cake for you, Mary Lou, for everything you have done in carrying on the legacy of your mother and continuing to help patients with blepharospasm and supporting all the research efforts as well as educational efforts on behalf of the Blepharospasm Research Foundation. So, Mary Lou, thank you, and I want to thank all of you for coming. Come and visit us.